Bismillahirrahmanirrahim. My name is Husnan and I'm one of the co-medical trainees currently working in the UK. This video is a part of our efforts to help our junior colleagues and medical students in starting their career in medicine. We've chosen this topic of tachyarrhythmias because this is an important and a common presentation that we see in our day-to-day practice, and this is actually one of those presentations when if the patient has a tachycardia, it has a tendency to cause anxiety in the attending physician as well, leading to tachycardia in the attending doctor as well. So hopefully we'll try to simplify a few things and we will try to focus on how to manage these tachyarrhythmias. So by the end of this discussion, we should be able to know what are tachyarrhythmias, and we should be able to know the basic emergency diagnosis and management of the most common tachyarrhythmias. We will start as per this layout. We will start with the definition and then move on to the diagnosis and then emergency management. We will basically be focusing around the emergency management as per the ALS Resuscitation Council UK's tachyarrhythmia pathway. So arrhythmias are basically of two types: bradyarrhythmias or tachyarrhythmias. So as the name of course obviously suggests, tachyarrhythmias are those arrhythmias which have got a high heart rate, that is a high heart rate of more than 100. So any arrhythmias with more than 100 heart rate is tachyarrhythmias. So there are many mechanisms that can lead to the production of a tachyarrhythmia, but the most common is the phenomena called the re-entry phenomena, which basically means that a re-entry circuit develops, and some impulses, they are generated continuously and then they travel in a circle, and this circuit may be around a damaged tissue of atria or ventricle, or it may actually involve both atria and ventricle. So the circuit may include that the impulses are starting somewhere, for example, in the atria, going down into the ventricle and back into the atria, and so on. As we all know, the normal conduction pathway. So it starts from the SA node, goes the impulse goes into the AV node, and then from the bundle of His goes into the right bundle branch, and then the left bundle branch, and then via the Purkinje fibers, which it goes into the ventricular myocardium, and this is how the normal impulse travels. This is called a sinus impulse, basically. A classification. So this is the most simplified and clinically relevant classification. So all we need to know in a tachyarrhythmia is if the QRS complex of that particular tachyarrhythmia, if that is narrow or broad, and if the impulses are regular or not. So these two things help us to classify and actually manage the tachyarrhythmias as well. So I would like to explain these things in a bit more detail. As you can see that the narrow complex, it says in the bracket, the origin should be of the arrhythmia would be from atria or the atrioventricular area, which basically means the impulse would start from above, from supraventricular area, which is basically above the ventricle in the conduction pathway. And if you get a wide complex, the impulse can actually start in the ventricular myocardium itself, or it can actually be one of these causes, but through some abnormal pathway it can cause a broad complex as well. So as I'm sure you this needs some explanation, so let me explain these things in a bit more detail. So suppose this is our conduction system. So the top two chambers are of course the atria, and the bottom ones are the ventricles, and the impulse starts in the SA node, travels to the AV node, and then from the AV node it goes into the bundle of His. The bundle of His then divides into the right bundle branch and then the left bundle branch, and this in turn goes in to supply the myocardium. The left bundle branch actually divides into the anterior branch and the posterior branch, So these bundle branches then give rise to these Purkinje fibers, and then this supplies the ventricular myocardium. So when we say the uh, if the complex is narrow or broad, what do we mean exactly? So this is actually of course referring to the QRS complex on the ECG. So the normal ECG has got a P wave which represents atrial depolarization, and then a interval, PR interval, which means which signifies the delay uh, in the AV node, and then the QRS complex. Then the QRS complex signifies the ventricular depolarization. T wave, of course, signifies the ventricular repolarization. Anyhow, so we would use this QRS complex on the ECG to basically work out what type of arrhythmia we have got. Now, whenever we see a narrow QRS complex on an ECG, this basically means that the impulse has gone through this pathway, and this pathway that's been highlighted, this is normal, because normally when the impulse goes down from the AV node to the bundle of his, and then from there to the right bundle branch, and then the left bundle branch, and then into the ventricular myocardium. So these impulses are transmitted simultaneously and very rapidly to both the ventricle muscle walls. So because of that, we see a narrow complex and not a broad one, because if the impulse were to travel slowly through the ventricles, then we would see a QRS complex which is a bit broader. So if we see a narrow complex on ECG, which means that the pathway from AV node up till the Purkinje fiber, this is working okay. But if we see a broad complex on ECG, this can signify one of two things. So broad complex can occur if the impulse starts in the ventricular myocardium. So this is the first mechanism to produce a broad QRS complex, because for example, if an impulse starts here in the ventricular myocardium, then it will have to travel from the myocardium from the right side, and then it will travel to the left side, and then since it is traveling to the ventricular myocardium, it will be transmitted slowly as compared to when the impulses are traveling simultaneously from these two fibers and then the Purkinje fibers. So the slow conduction is represented on the ECG as a broad QRS complex. So this is one way how you can get a broad complex on a ECG. Now the other mechanism which can cause a broad complex on an ECG is that the impulse generates from above the ventricle, but there is some abnormality in the conduction system which causes the uh, QRS complex to appear broad. This could be a problem with the bundle branches, which we call the bundle branch blocks, which could be right bundle branch block or the left bundle branch block. For example, simply speaking, for example, suppose this bundle, which is the left bundle, is abnormal at this point. So when the impulse is traveling down from the SA node to the AV node and the Purkinje system, then the bundle of His, and then when it needs to travel down, it will not be able to go down from here. So the impulse would prefer going from the right side, right bundle, and then would depolarize the right ventricular myocardium, and then from the myocardium the impulse would travel towards the left side of the heart, the left ventricle. So since again the impulse is traveling from the ventricular myocardium, it would be slower to go, and then the complex that we will develop is broad. So this is one way. The other way is if the impulse is actually being generated from above here, again supraventricularly, but instead of the normal pathway, the impulse uses an abnormal pathway. Sometimes what happens is there congenitally there is an abnormal pathway which is present between the atria and the ventricles, which is obviously not normally present. So normally the only point of where an electrical impulse can travel from the atria to the ventricle is the AV node. So the atrias and the ventricles are electrically isolated, and the only point of connection between them is the AV node. But if there is this bundle there, which is pathological, then there are two pathways now where the impulse can go down from the from above the ventricle into the ventricle. Either it can go down from the AV node or from this bundle. Now suppose there is an impulse that is generated somewhere here, and then it goes down from here instead of from the AV node. Then if the impulse travels down from here, it will depolarize the muscle first, the ventricular muscle first, and again, since it's passing through the slowly conducting ventricular myocardium, this will translate on the ECG as a broader complex. So now we have seen the second mechanism is this is called pre-excitation, because the ventricular muscle is excited from a different route prior to it being excited from the normal route, or this means basically via accessory pathway. This accessory pathway is of course called the bundle of Kent, and this whole disease is actually called Wolff-Parkinson-White syndrome. So Wolff-Parkinson-White condition. So if someone has this bundle of Kent and they develop tachyarrhythmias, then we say this person has developed Wolff-Parkinson-White syndrome. So syndrome means having an accessory pathway and having a tachyarrhythmias. So in summary, if you want a broad complex, either the impulse should generate in the ventricle itself, or it can actually generate from above the ventricle, but there needs to be either a problem with the conduction system causing unequal conduction, or there needs to be an accessory pathway. So this is in summary what can cause a narrow or a broad complex. Again, a narrow complex means that the impulse the pathway from AV node and below, this is normal. So this means that whenever an impulse uses this pathway from AV node, bundle of his, and the right and left bundles, then this will translate as a narrow complex on ECG.